Good morning. Can everyone hear me? Good morning, everybody. Thank you so much for being here. I am Sarah Daschle. I'm president and co-CEO of the Alliance for Health Reform. And for those of you who don't know us, the Alliance for 25 years has been a trusted source of nonpartisan health policy information and dialogue here on Capitol Hill and for health leaders around the country. We are so thrilled to have you with us today for the very first in our 25th anniversary series on the future of healthcare. And today, obviously, we are focused on the future of health insurance. We chose to do this series because healthcare, of course, is as important as it's ever been to our country. And the decisions we are making today, this week, this month, this year, they're all leading up to the future of healthcare. And so we wanted to take a look at what's going on today, but also envision the future and think about where we're going with all of this. So we all have a lot of day-to-day responsibilities, so we're all really happy that you've taken the time to be here, and we're thrilled to have our sponsors here as well. Thank you. Now, the other thing about the Alliance, of course, you are all the best audience. We have the best audiences, and so I just want to quickly mention a couple of upcoming events that we're going to have. On May 5th, we're going to have a follow-on to this summit today. We're going to actually have a congressional briefing over on Capitol Hill, and it's going to be on a topic based on what we hear today, what we want to expand on, what we want to focus on more. So we hope you'll fill out those blue evaluations. Those never change, and tell us what you want to hear. Finally, our next two summits, which will take place this summer and then this fall, will be focused on the future of chronic care and the future of the healthcare workforce. So we hope you will join us for those as well. So thank you again for being here, and without further ado, I'm going to turn it over to Marilyn Serafini, my co-CEO. Thank you.
Fantastic. Thank you, Sarah, and also glad everyone could be here with us today. I have the pleasure of thanking a lot of people who made today's event possible. We have 3 annual summit sponsors who are with us here today, and we're really excited about that. Anthem, Health is Primary, and Ascension. We also have a handful of sponsors who are sponsoring this particular health insurance summit, and we're just delighted to welcome the Blue Cross Blue Shield Association, DaVita, the Association for Community Affiliated Plans, which we know as ACAP, the Children's Hospital Association, and CVS Health. I'd also like to recognize some board members from the Alliance who are here with us today. We have Reed Tuckson, who's going to be moderating the first panel. We also have Tom Scully, who's going to be part of the first panel. I didn't mention that Reed, who has a long history in the healthcare community, he's with Tuckson Health Connections, his own firm. And Tom, of course, former CMS administrator, now with Welsh, Carson, Anderson, and Stowe. And also we have Kirsten Sloan, who's with us here from the Cancer Action Network, and she'll be part of the final panel. Just a couple of housekeeping matters. If you are tweeting today, please use the hashtag #FutureOfHealthcare. We'll be monitoring the Twitter feed, and if you have questions, that's one way in which you can ask questions. I'm going to tell you about a couple of other ways in which you can ask questions. We will have roving microphones. If you have a question, please raise your hand, and one of our staff members will bring one of these trusty mics to you so that everybody can hear you. The other way to ask questions is that in your packet you have a green card. And if you would prefer, write your question on the green card, and one of our staff members, just hold it up, and one of our staff members will come and collect it and bring it up to us. I will tell you that with today's sessions, we're going to be having an armchair conversation, and then we will open it up to questions. So we will probably have time for 2 or 3 questions for each panel. So I will say that you'll have a much better chance of getting your question asked if you raise your hand and take the microphone, but we will try to do the best we can to answer as many questions as we can. So before we get started on our very first panel, I would like to welcome to the stage 2 of our annual sponsors, Mark Hayes with Ascension, who's going to provide just a very brief opening remark, and then we'll turn it over to Glenn Stream, who's with Health is Primary. So Mark Hayes of Ascension.
Thank you, and good morning, everyone. We're so glad to have you here. My name is Mark Hayes. I'm the Senior Vice President for Federal Policy and Advocacy for Ascension. For those of you that don't know about us, Ascension is the largest nonprofit health system and the largest Catholic system in the world. We are very pleased to be a sponsor of this summit. Such an important topic and so very timely. We're so glad that you are here, and thank you for coming. I'll turn it back over to Marilyn.
Great, thanks very much. And now Glenn Stream with Health is Primary.
Good morning, everyone. I'm Glenn Stream. I'm a practicing family physician in Southern California, and here in my role as president and board chair of Family Medicine for America's Health, which is a collaborative effort of 8 national family medicine organizations. Health is Primary is our public-facing communication effort to have the public understand the importance of a strong primary care system to the health of them and their family and their community. I would agree. The timeliness of this topic is just so important about health insurance reform in that there's opportunities in that process to strengthen our primary care system, and the transition to more value-based payment that can promote that primary care foundation is really critical. So we're pleased to be here and really want to thank the Alliance for sponsoring this series. Thank you.
Great, thank you so much. So I'll ask our folks in the back whether we're ready to bring up our first panel or whether we'll have a couple-minute break already. Okay, we will start our panel in about 1 or 2 minutes, so have coffee. We're not really having a summit. We'll be starting in 1 or 2 minutes promptly at 9 o'clock.
Oh, here they are.
Oh, and they're here. So without further delay, I will introduce our first, our moderator, Reed Tuckson, who I introduced before as an Alliance board member, is going to introduce our first panel, and take it away, Reed.
Well, thank you very much. And we're really excited about presenting this conversation with you. We want to make sure that we get your voice in the conversation. So at about 30 minutes in, we'll turn to audience participation. So just know that you will have an opportunity to participate. This conversation is designed to set the stage for the more in-depth panels that will follow. But we're going to kick it off and talk about how to stabilize the individual insurance market and what's likely to happen with Medicaid going forward. There's been a lot of, obviously, activity lately, and we're sort of looking at the state of play, where Washington is going, but also from the point of view of our 2 panelists, where should we be going? Let me begin, Senator Tom Daschle. You served as the United States Senate Democratic leader for more than a decade. You are the founder and CEO of the Daschle Group, a full-service strategic advisory firm that advises clients on a broad array of economic, policy, and political issues. Particularly relevant to this conversation, you are a co-founder of the Bipartisan Policy Commission, and you co-chair its Commission on Political Reform and Health Project. If we are to achieve bipartisanship, if we are to have solutions that cross differences, it's clear that we have to understand where people are coming from. How do they think about problems? It would be good to understand the motivation and objectives of the different camps. In a non-politicized environment, most people would see the objective of covering all Americans for health care and access to health insurance as a terrific social good. What are the priorities and purposes that drive the various factions? And I'm curious, in terms of as we sort of think about what could be on people's minds, maximizing the health outcomes of all Americans, providing access to quality and cost-effective care for all, decreasing federal expenditures, paving the way for major tax reform, paving the way for entitlement reform, political ideologies, focusing on diminishing the role of federal government versus state control and flexibility, keeping campaign promises, or just sticking it to the previous administration. What are the motivations that you sort of see that are defining how people from different camps approach this issue?
Well, Reed, that's an interesting question and a good way to start the conversation. Let me just say how pleased I am to share the dais with Tom Scully. I've been a huge admirer of his for a long, long time, and it's been a little while since we've seen each other, so it's great to be with him on on such an auspicious morning. I think I would say that in the context of health reform in particular, I think it's surprising to a lot of people to, as you talk about the similarities that may exist in terms of what motivates people. I think people are motivated by the realization that healthcare costs too much in this country. It's not as accessible as it should be in this country. The quality isn't what it needs to be in this country. I think there's a lot of consensus around the reasons why those problems exist. And there may even be a consensus generally about what the goal is. What are we trying to accomplish? And if you'd ask a liberal or a conservative or a Republican or a Democrat, it seems to me that they would say something to the effect that what we'd like to do is to build a high-performance, high-value healthcare sector with better access, better quality, and lower cost. That is what motivates, I think, most people as they think about health. I think the real rub comes on what the role of government is. And for the last 100 years especially, we've attempted to try to resolve that question. What is the role of government in achieving a high-performance, high-value healthcare marketplace? And over the last 100 years, through a series of compromises, we have come to a point where I believe we've got what I call a $3 trillion public-private partnership. Mm-hmm. That's really what we've got now. We've got public entities and private entities, commercial and government, and that collage of subsystems is really what has created this public-private partnership. The ACA, 7 years ago, was the latest iteration in identifying and sort of describing what that partnership looks like. But it really comes down to what is the role of government today, and that, I think, will continue to be a source of division within the ranks for a long time to come.
Great, thank you. Tom Scully, you are a former administrator of the Centers for Medicare and Medicaid Services during the George W. Bush administration. You're now a general partner at Welsh, Carson, Anderson, and Stowe, a private equity firm. Particularly relevant to our conversation, you served as president and CEO of the Federation of American Hospitals, which represents more than 1,000 investor-owned hospitals. Same question, how do you sort of see the motivations of the different camps?
It's really never fair to put me after Senator Daschle, is it? That's not really quite. But anyway, we've been friends for a long time. When I was running CMS, he was the leader in the Democratic side of the Senate. And shockingly, we actually talked to each other. And he was always incredibly nice. So I would advocate that to start. But anyway, we're also in the same law firm for many years. So we've been good friends for a long time. Yeah, so I would say, I assume my reason for being here largely is to give the Republican side of the thing. So I'm not saying I agree with all this, but how Republicans look at this, I'll try to project that. I think that they look at it as, number one, they were angry, obviously, in 2010 that this thing passed on a party line vote. And they would have said, you should have been more bipartisan. Now they're obviously going roughly back the same way and seem to be trying to repeal it on a party line vote. So you can argue that either way. I think it's a better model. If Senator Daschle remembers, we did Medicare Part D and Medicare Advantage back in 2003 and 4, which were also extremely controversial. And we did, in fact, make a huge effort to pick off, 10 Democrats in the Senate, or I think there were 9, and a handful in the House, just to basically take the edge off it. So I think, number one, I think it's never a good idea to do big healthcare policy. They're creating the ACA, repealing it by a party line vote. And I think we're in a much tougher world than we used to be. So I wish it was a little friendlier. From a Republican point of view, I think they look at it as the ACA was just too big, and they wouldn't have done it that large. And if you'd asked them, in 2010, they would have probably I would have been comfortable probably with doing 50 or 60% of it. So just on the Medicaid side, and I think Medicaid gets too little attention, the money and the real issues are in Medicaid expansion. When I got to OMB, I was at OMB in 1989. We had 20 million people in the Medicaid program, and it cost $50 billion a year. Before the ACA, before it passed, we had 55 million people in the Medicaid program in 2010, and I think it cost about $400 billion a year. Today, we've got 77 million people in the Medicaid program, and it's about $600 billion a year, okay? So what's the real difference in the next 10 years Republicans want to do? If you look at the Ryan bill, if you look at the Ryan bill does, you'd have 75 million people in Medicaid in 10 years, so a couple million, you basically freeze it in place. You'll lose a few million people from the phasing out. You're assuming the governors will drop some people. But the growth of Medicaid goes from $600 billion in the Republican plan to $750 billion in the next 10 years. And the Republicans' attitude is this thing's growing too fast. It's done too much. We're going to freeze it in place. If you continue with the ACA for the next 10 years, you go from $600 billion to $950 billion. And you go from 77 million to 97 million people. Those are just the CBO scores. But people don't look at that. If you look at it from a purely Republican view, their attitude is this thing is too big, it's out of control, let's freeze it where it is. Most of the northern states had already done the expansions. The 31 states will roughly stay where they are. So if you think, where's the inequity in that? Where's it unfair? It's the 19 southern states, largely southern and western, that didn't take Medicaid expansions. Those governors, to my amazement, seem to be okay with that. But that's really what the Republicans are saying is enough's enough. We're not doing it anymore. We're going to make the states pay some of their match after 2020. We're going to basically not do any more expansions. We're going to freeze it in place. Even doing that, spending goes from $600 billion a year in Medicaid to $750 billion a year in Medicaid. So to them, it's largely a fiscal issue, and how big and how fast and how much. So you're not really cutting Medicaid. I mean, you're basically freezing it where it is. And some of the northern states, you're telling the governors you're getting 90, 95, 100% matches. You know what? We're going to gradually scale you back to your match rate. So it's basically, to me, that's if you look at the bill, the Republicans were irritated. A lot of people in this room, I think, if they don't put the two together. In the Republican bill, you had a 0.9% HI tax, permanent for every American, it's paying 0.9% more in income tax for theoretically Medicare taxes. Another 3.8% on top of that for basically was a capital gains tax on investment. Those are permanent taxes. Those drove Republicans crazy. There's also a tax on devices, insurance companies. That's what paid for it. If you look at the bill, it's almost dollar for dollar. $880 billion is what you save by having Medicaid grow more slowly over the next decade, versus the taxes that disappear. It's literally almost dollar for dollar. Getting rid of the taxes today and freezing Medicaid where it is. So that's the Republican fiscal conservative side of it in a nutshell, I think. And the argument, the other side is, oh, you're heartless and you don't care about poor people and you don't want to expand it. I'd probably be somewhere in the middle of that debate. I would probably do a little more of it, not all of it. But I don't think either side's either completely right or completely wrong as usual. And the right thing to do is probably somewhere in the middle, and I don't think we have too many middle discussions anymore, sadly.
Well, let me actually deal on that issue. We'll come back and I'm going to drill into some of the details in your opening comment. But I think this notion, when you were in the Senate, there was clearly a much more opportunity for folks to get together from the different sides. A lot of that was driven, I think, by perhaps more compassion, more sense of caring, a sense that we are a great country that can solve problems. We have enough money to solve our problems for those that we consider to be important. Why isn't that the case now, and why is that? Are you seeing that as a major stumbling block to getting folk to sit in a room together and try to work it out? You're sitting in those rooms. What is it going to take to make those conversations happen and be productive?
Well, first of all, I think it takes leadership. I sometimes don't think we see the leadership necessary to bring people together. There has to be more opportunities for better communication, trying to resolve this. And Tom said something that I just couldn't be more emphatic about. Anything that's done on a partisan basis is a temporary solution. The ACA became a temporary solution because, and we can decide who was responsible for the fact that it became so partisan, but you just know that if it passes on a unilaterally single partisan vote, you're going to come back and revisit that. The only real bipartisan legislation is permanent legislation. And the only permanent legislation is bipartisan. But I would go to my assertion about the role of government, I think, is so much a part of how I look at this. I think a lot of times at the federal level, there's no disagreement about the importance of ensuring that people have access to health. The real question is, whose responsibility is it? There are a lot of Republicans who believe it's not the responsibility of government, that it really ought to be the responsibility of nonprofit organizations, of churches, of others to assist those who are in need of care. They also would shift a lot of the responsibility to state and local governments, not the federal government. I worry a little bit as federal policymakers that they tend to do something, and I'm guilty of this myself, I did this many times, that our solution is just to cut and shift, to cut the federal program, whether it's Medicaid or Medicare or CHIP or anything, and shift the cost somewhere else, onto the states, onto the private sector, onto the individual. And cutting and shifting is a common practice done by both sides. And that really doesn't solve the problem. It just shifts the problem and the responsibility to somebody else. A much better approach is to redesign and improve and go after the real core issues that are causing those costs to go up and those people not to get care. And that's a little harder to do.
Tom, this shifting then from the federal government to the state government Medicaid, what's your just overall assessment again? on how stable the Medicaid program is, and what does it look like from the point of view of governors? You mentioned 19 southern states that predominantly that didn't accept the opportunity to expand coverage, but what's going on in the governor's minds around Medicaid?
Well, so Medicaid is a wonderful program that provides a lot of great services for, I think, 77 million people this year, actually 98 million people. During the course of the last year, there were 98 million people. That's a big number on Medicaid at some point. It's a great program. It's structurally, and it provides great services. I think it's a structural disaster. And I think, I quote Senator Daschle, so I hope he still agrees with this. I've been a fan of a per capita cap, which is much different than a block grant for years for one basic reason. Since I got involved in the program in the late 80s, the states do a great job, but it was basically a matching program for many years. So the match is basically supposed to be 50-50 for the wealthiest states, you know, the Connecticut's and the Californias, up to 76% for the Mississippis. And that's the way it's supposed to work. Over the years, the states have come up with these wild, I would have done the same thing if I were a state Medicaid director or governor, but they came up with these cost shifts for provider taxes. You all have them, donations. So the states basically found a way to change their matches. So the Medicaid system financially is broken. There's not a human being in the United States, zero, even at CMS, that can tell you what the match rates actually are for the 50 states and the 6 territories. Now think about that. If you went out and looked at it, you know, New Hampshire puts not one penny into its Medicaid program. Romney Care, which everybody's very proud of, and I was a Romney advisor in the campaign. I love Romney, he's a great guy. You know how much Massachusetts money is in the Romney Care program? Zero, not one penny. It was all funded through a Medicaid scam. And not many people know that. That's a fact. Massachusetts knows that. The point is, it's just not, the program financially is broken. So the reason to go to per capita cap has nothing to do with saving money. Conceptually, it has to do with saying, let's stop the musical chairs, get rid of what they have, whether it's, you know, South Dakota or Virginia or whatever. And everybody will, you know, we'll give you what you have today, and we'll give it per capita adjusted, you know, for recessions, for the rest of the time, adjusted for inflation, so that the financial games can stop and people can focus on providing good care. So I think the governors are looking for flexibility. I think a per capita cap will give them that. You can discuss how much you want to put in or take out of the program. But the program, one of the problems for the last 30 years, and I've been very involved in it, is that if you're a Medicaid director, you spend more of your time trying to figure out how to cost shift to the federal government than you trying to run your program. And I think the program is a great program. But for $600 billion, $600 billion, by the way, if you are not on Medicaid, each one of you is paying $4,000 in taxes each year to pay for Medicaid. I'm more than happy to pay for that program, but I'm not really happy to find out that there are no financial rules, and it's a structural, any government class in the country that could go out and explain how it works would throw up. It's outrageous the way it works financially, and it ought to be fixed. So whether you're going to shrink it or grow it or expand it or whatever, the mechanism behind the second biggest program in the federal government is fundamentally broken. Is that, I don't know if
you think about things like the 1115 waiver program, which allows all of the flexibility of sharing costs with the enrollees. Is that a good way to approach it? Is that a reasonable kind of a model that we can use going forward?
Well, first of all, Tom is exactly right with regard to the formulas. There's no, the FMAP system is so convoluted right now, and it's really ended up sort of a collage of deals that governors have made with the federal government over the years, and there's an unfairness as you look at the distribution today. It's always one of the most contentious aspects about healthcare generally is the allocation of resources through Medicaid, through the FMAP system. And so that needs fixing without a doubt. We have a demographic explosion about to occur with seniors, and I think as we look at ways with which to address that demographic explosion, it's going to be all the more important that we give states flexibility. So I'm a huge believer in waivers, and the 115 program is a good example of that. We've got to give states as much opportunity to adjust to these demographic changes as we can, but we still are going to be faced with enormous financial challenges going forward, with or without all the waiver systems that exist today. So we've got to work on ways with which to finance and organize. I do think that Medicaid, one can say what you will about the financing of it. The one thing I am encouraged by is the degree to which managed care has become part of the Medicaid system, unlike Medicare, where we haven't really seen the same degree of evolution and opportunities for addressing that. That's changing, but the opportunities really to experiment and to find ways with which to explore more efficient ways of providing care, in part because we have the waiver systems, has allowed for managed care to play a more important role in Medicaid than it did 15 years ago.
One of the experiments that people are talking about is asking and forcing Medicaid-eligible people to work as a work requirement. How do you feel about that?
Well, I think that's overplayed as an issue. 13% of the people are affected by it. A very, very small percentage. The fact is, most Medicaid recipients do work. A lot of those who don't are taking care of an elderly or sick member of the family and don't have the capacity to work. So I think it's an issue that generates a great applause line in front of crowds around the country, but frankly, I don't think it's really that necessary.
Comment?
You know, I agree. If it makes, in some states, it's going to be popular, and if the governor wants to do that, to get a waiver, and I don't have particularly troubled by it. I don't think it's caused huge disruptions, but I do think it's a little bit overblown as an issue. So, you know, I think waivers are great. If you look at the states, if the waivers are done for creative financing, which is why a lot of them are done, I mean, I won't get into which ones, but I've done a lot of them, and I'm not a big fan. But, you know, if you look at California, which is heavily managed care, spends probably a third of what New York does per capita, has a big Medicaid program. It's a very efficient Medicaid program. It's run very well. They're one of the first, you know, theoretically a liberal state, was one of the first to go to heavy managed care. They've run it very well. And so I think giving the states the flexibility to go run their programs effectively, which California has, Arizona's done a great job, I think, with their managed care program. That was one of the biggest waivers. They were the last state into the Medicaid program. So I think the state should have flexibility to go run their programs. And the flexibility is to be a partner with the federal government to run a program. That's terrific.
I know Peter Lee, who's in the audience, is going to be happy to hear you say that. He'll be up next in the conversation. Real quick, before we turn away from Medicaid, you talked a little bit about alternatives to block grants or other kind of proposals. Can you just give a little bit more color on that so we make sure we understand where you are on block grants and alternatives to block granting?
Well, I mean, the two alternatives, which I'm glad you're still for, have always been block grants and per capita caps, in my view, are completely different animals. A block grant basically says if the state of New York's budget for Medicaid this year is $60 billion, which I think is by far the biggest per capita. So it's $60 billion. You'd be saying in New York, here's $60 billion. We're going to give that adjusted to CPI or medical CPI for the rest of the time. If we have a recession and your population goes up by 15%, tough luck. You get a block grant. You know, call us later. That's how much money you're getting every year. You know, that's not particularly sensitive to various disruptions in the economy. A per capita cap says if you're spending $60 billion and it turns out to be, let's say it's $10,000, just to pick a number, $8,000 per head. It's broken up in different categories for disabled and for aged and for women and kids, but just generically, let's say it's $8,000 a person. That the per capita cap puts in per person, the benefit remains an entitlement per person, which is also a big difference. So it's still an entitlement program. And if you have a recession and the population goes up, your funding goes up per capita per person. That's a much more flexible system that's much better for the states and protects much more in a recession. And I think there's a huge difference between the two, and I think a lot of times people throw them together, and I don't think they should be.
But did you have?
No, Tom's exactly right. There is a difference. I think the fundamental question on a per capita cap is, do you have a cost of living adjustment that adequately takes into account what costs are incurred? Sometimes health costs far exceed the costs of cost of living generally, and so having some mechanism that accounts for those significant increases in costs will be one of the key questions. But there's a big difference. I really don't think block grants have much of a chance of getting much attention in Congress, but there are those who support it.
Let me switch to the exchanges and try to get a sense of the magical date of June 21st is upon us soon, where the insurers have got to make a decision about whether they're going to be in or out. That we've seen already this week in Iowa, some important exit, 21,000 people now will be negatively affected. I think I saw this morning in the news, Aetna is out in Iowa as well. What's going to happen? Is the administration going to prop up the markets, or are they going to let them implode or explode?
Well, Tom's...
Yeah, you want to take that one?
Yeah, I'll let Tom answer that question.
I think they're going to do I don't know. I haven't talked to Secretary Price, who I think is a great guy. I've known for a long time, about it. I don't think they're going to prop up the markets. I think they're probably pretty upset about a lot of things that happened, including the Obama administration in the opinion of Republicans, created these premium support payments that went beyond the law. The first step they have to decide if they're going to continue those for a year. That's a very tough call. I mean, I think they probably were not appropriate. $7 billion that some people would say, basically inserted into the payment system, $7 billion a year of subsidies for insurance premiums that were not in the law. So are they going to continue for another year? I think to avoid the disruption, if I had to bet, I bet they probably will. They're not happy about it. I don't think they think it should have been there. I think they would love to change the risk bands and change the risk rating bands. I think they can't do that without a change in law. I think they can do everything they can to support the insurance companies that are in there to make their lives easier. And if I had to bet, I'll bet they'll continue the subsidies for the premium subsidies for a year, the low-income premium subsidies. But I don't think they're happy about it, and I think they're going to try to ease out of those as much as they can. I think what the insurance companies, and you obviously know that as well as anybody, are looking for stability and predictability. And I spent a lot of time with Senator Daschle 15 years ago trying to get, we had a similar drop out of, we were down to 3% of people in the Medicare Plus Choice program, which Medicare Advantage in 2001. And the insurance companies were dropping like flies, and they didn't want to be in that business. It was a miserable business, and we threw a lot of little things at them for a couple of years to try to show them that we felt their pain and we're going to talk to them and listen to them. We made some very big changes in 2003, but I think if you're running an insurance company, the insurance company, in my view, and I'm the chairman of the board of a small insurance company, is a predictable business. You want to make a 4 or 5% margin. You're a partner with the government, whether it's Medicare and Medicaid, and you want to know that there's some certainty there. And if you're going to lose money, you're going to get out. It's just a fact of life. So I think the administration will do everything they can. I don't think they're trying to blow up Obamacare or the ACA. They want to keep this going reasonably, and they want to phase out what they consider to be excess subsidies. And I think they'll do everything they reasonably can.
Let me make sure on the predictions, and I'll go to you and then you, in terms of the important, again, magical date of May 22nd, when the decision has to be made about whether the government is going to challenge or drop the suit on cost sharing. So these subsidies are either going to happen or they're not, and we're going to know very shortly whether or not the lawsuit by the House is going to be dropped or not. What do you think is going to happen?
Well, I don't know. They haven't asked me. If I were them, I probably wouldn't drop the suit. You
wouldn't do it.
I would probably pay the premium, pay them for this year to keep for the next year to keep the system going, and the fundamental suit has been about this is actually effectively the correct thing to do under the law. I happen to think it was not in the law, so I would not drop the suit in principle because I don't think in the long run they want to do it to keep to keep the companies in 2018 and keep it going. I think it's highly likely. Certainly, I know a lot of people on the Hill want to keep the subsidies going. In principle, they can't stand them, and they're not happy it happened. In reality, they don't want the market to blow up. So I think it's a very tough call.
Well, I think the subsidies, one way or another, are going to continue, only because the viability of the individual market is so dependent upon them. But that's 1/3 of the formula for survival and viability. The subsidies are key, and I think Tom's right. They're not happy about it, but the reality is, without subsidies, you're going to see a dramatic decline in enrollment, and that's going to devastate the individual market. The second issue, though, is equally as important to retaining that pool, and that's having some sort of a mandate, some sort of a requirement for participation. The Republicans have come up with a different option that I don't think even CBO doesn't agree. It doesn't believe is as effective as a mandate, but keeping a healthy and robust pool is critical to the individual market as well, and we may not have that. And then the third thing is the thing that Tom really deserves a lot of credit for. We created a risk-sharing program for Part C and D that have been incredibly successful. And I have now advocated for a long time that if we did that for the ACA, most of the risk-sharing challenge would be gone. But we don't have adequate risk-sharing today in the Affordable Care Act. And until we address it, reinsurance or some other way with which to ensure that public-private partnership is really a partnership and there is balance, we're not going to get there. And so, but all we have to do is to do what Tom and the smart people around him at the time realized was necessary to make Parts C and D viable. And if we did that, I think we'd be in a very good position today.
Tom, let me just ask you, in terms of your weighing in on the individual mandate, enforce the tax penalty or not?
I think sometimes these things are semantics. So I'll give you a kind of, he was involved in this back in 1990 when we were having a big fight over child care. And Republicans wanted to do vouchers and Democrats hated vouchers, and we came up with a compromise. We changed the name to certificate, and all of a sudden everybody was okay with that. I don't know if you remember that with Senator Mitchell. And we got a big child care problem because it wasn't vouchers. You know, mandate or not a mandate, if you're putting in a tax penalty and requiring people to get insurance, you can call it whatever you want. I think we got to get away from the mandates. The individual mandate was originally a Republican idea. It was originally a Heritage Foundation idea. I happen to think it's necessary to make the markets work. I think mandates set off rockets with conservatives. They just don't like the idea of mandate. We don't like telling anybody what to do. That's not what the federal government should be doing. So, you know, we're willing to do tax penalties. We're willing to do various tax incentives. I think we got to come up with a middle ground that's a non-mandate similarity.
All right. By the way, we're a couple of minutes away from getting Q&A from the audience, and so I just want to make sure there's a mic there, and so we'll be turning to you in just a minute. We've talked a lot about access and different ways of trying to get access and how do you afford it. The question also becomes access to what? You can really make stuff cheap if you give people crappy plans. How do you think about this notion of essential benefits? What should be in it? Who should decide it?
Well, that's, again, another great question about the role of government. I don't think that the Silver plans are all that great a deal, frankly. When you've got $7,500 deductibles, it really makes it hard for a lot of people to afford health care, even if they are insured. But at least the Essential Benefits Program, just as we do with almost anything, you buy a car, you have certain expectations about what that car has to do. You buy a house, or you buy a furnace, or an air conditioner, or a refrigerator. There are certain minimum requirements to be able to define that particular product or service as a product or service that you think you're buying. That's really what essential benefits. I mean, in the past, what we had in the dark days was insurance being sold and people not really having a clue what's in it. And so when they first find out that they aren't insured for half the things they thought they were, it created even greater uncertainty. So having that floor, to me, is an essential part of the insurance system. But again, it's a very arguable question. How far do you go? I do think preventative health services are key. And I think also, if you look at what that pool is supposed to be, making sure that you've got healthy people helping to fund the unhealthy ones is really a part of it as well. So to me, it's an essential element to a good insurance program.
How do you see it?
So I think the whole debate, since I'm a cheap, cold-hearted Republican, I'll give the Republican side. The whole debate is about who do you want to subsidize and how much, and how big do you want these entitlement programs to be, and I think it's similar with Medicaid. I would probably advocate covering people to 138% of poverty, because I think it may be the right thing to do. And I think you should subsidize those people and give low-income people health care before you go to 400% of poverty. I've been a huge critic, as Senator Daschle knows, of what the ACA did to go to 400% of poverty to subsidize health care. I think is unsustainable. That's 67% of the population. It's not a lot in Washington, D.C. or New York, but if you go to rural South Dakota, $97,400 a year is a fairly good living in rural South Dakota and a lot of other parts of this country. And if you buy a $15,000 silver plan at that level, you get a $5,000 subsidy. I don't think you can do that type of income stream, and I think it's a mistake. So my view is we should cover low-income people on Medicaid, and above Medicaid, just as we've done with Quimby's and Slimby's and other places, you should probably subsidize people as more and more, but where do you stop? I don't think you go to 67% of the population. And I've had a lot of debates. Peter Orszag frequently says, oh, Scully, you and I agree a lot on this. You want to go to 300% of poverty, and we want to go to 400% of poverty. And that's not that big a deal. There are 50 million people between 300 and 400% of poverty. It's the middle class. So the issue is, who do you want to subsidize here and how much? And I think Republicans' view is subsidize poor people, absolutely for sure. How's Medicaid structured? You can debate that. Subsidize middle-income people on the lower end. But at some point, people should get a catastrophic stop loss. I would say that if you're at whatever, 55, 60% of the population income-wise, maybe you need a catastrophic stop loss. So if you happen to get cancer, you get hit by a bus, you're going to have maybe a $7,000 deductible and not have to pay a $400,000 bill. That's what this is about to begin with, to make sure that people who are not poor, weren't uninsured and go into the hospital and have $1 million bill that they had to deal with, that the hospital had to eat. I used to run a hospital association. The biggest issue for the hospitals is not the $2,000 deductible, the $7,000 deductible. Yeah. It's the $2 million unpaid bill.
But outside of the financing, again, who should be determining, or should anyone determine, what is at least the kind of basic floor, the essential package. I mean, if at the end of the day you try to sell this politically, people are going to want to know, okay, what am I getting? And are we going to try to avoid that? Are we going to basically say it's state by state? What's the approach do you think ought to occur?
I think the Republican answer to that, I'm not sure it's necessarily mine, but I'll tell you what I think it is you get 50 states, let's come up with a basic federal subsidy level for people up to 350% of poverty for a catastrophic stop loss, and let the states decide what it is in that state. And Utah may have a different idea of what essential benefits are than South Dakota or New York. I'm not sure that's the answer that everybody wants to hear, but I think that's where it's going when Republicans running things.
Senator, any further?
Well, I obviously would disagree with that. I think, there's chronic illness in this country is really an issue that we haven't adequately addressed. Long-term care, something we haven't addressed. Catastrophic plans only address, for the most part, acute illness, and it ignores the need for preventative health and good prevention efforts overall, population health. It doesn't address the many issues. There was a poll recently of people were asked, if you had an unexpected $400 medical bill, could you afford to pay it? And 52% of the people said no. They couldn't afford a $400 unexpected medical bill. So it gives you some sense of the incredible price sensitivity there is to healthcare today. We're the only industrialized country in the world that doesn't have universal healthcare. Every other country's figured it out. It seems to me in the year 2017, we ought to be able to figure it out too.
Let me just make sure as I turn to the audience, but since you said it, the prevention fund, is that going to be politically complicated to keep that? I mean, is there any reason why there couldn't be a bipartisan decision to keep the prevention fund intact?
Well, it's being used as a piggy bank for almost everything else at this point. So it's there, but it's not for prevention generally, and that's the sad thing. But no, the answer to your question is that shouldn't be controversial. It wasn't, initially the concept, it makes so much sense, but I frankly, I think it's going to be drawn down for other purposes.
All right, good.
Good morning. My name is Chris Urban. I'm with Kaiser Permanente, and I would argue that out of control healthcare costs are attributable in part to three key words, and that is fee for service. And I'm curious, when do you see our system, whether it's a public program such as Medicaid or Medicare or private sector offerings, moving from a fee for service concept to a value-based reimbursement concept? Thank you.
Well, I'll start. I am emphatically in agreement. I think we're going to be moving much more slowly on fee-for-service reform and the migration away from fee-for-service to other approaches, bundled, capitated, global, than I'd like. I think value-driven care is something most people can support, but I think it's harder to define. And in part, if value is quality over cost, quality is still a measurement issue that challenges us, and we haven't been able to figure how to address quality in a value-driven context as much as we should. That's going to take some time, and one of the biggest drivers to doing that is probably Medicare. I think the previous administration was on a track to do that. They've set some pretty ambitious goals under the Medicare program to do that. Frankly, I don't know if it shares the same priority in this administration. So I'm not as optimistic as I would have been a couple of years ago.
Tom Scully, let me ask you on that, especially in looking at it through a private sector lens. I wonder whether you would agree that the private sector hasn't really made some inroads into being able to establish guidelines and criteria for doing value-based reimbursement.
I think we should just put everybody in Kaiser. How's that that'll make them happy. Kaiser's a great system. Look, we've made big changes. When I got this to HCFA, CMS, in 2001, we had 3% of people in the Medicare Advantage program. It's now 33% and growing. I think it'll be 50% in 5 years. That's capitation. That's private health insurance. Has turned out to be pretty good, and it's actually turned out to be very bipartisan, thankfully, over the years. Medicaid went from 10% in 2000 of Medicaid managed care. It's now, depending on whose number you count, probably over 80%, led by California and other primarily Democratic states. So I think the move to private health care is definitely happening. And the reason I like it, Republicans like it, is because I don't like fee-for-service for one basic reason. Price fixing has never worked in the history of mankind, any place, anytime, ever. And I was very involved in creating RBRBS, which is the fee-for-service 1989 thing we did. And at the time, I thought it was a great idea. In hindsight, paying every doctor in every hospital the same thing has turned out to be not a problem. And so my view is, as long as they're well regulated, if you can take those populations instead of the government fixed prices and give it to Kaiser or a Blue Cross plan or Aetna or whoever, and say, here's $15,000, call me next year, you can make a 4 or 5% margin. I just think the behavior and the outcomes are much better by having a little bit, I wouldn't say it's a lot, a little bit of markets come to bear, and that's roughly what's happened. So I think we've made great movement. These are big programs, things happen relatively slowly, but if you'd asked anybody in 2001 if they thought we'd have a third of the Medicare program in Medicare Advantage at this point, I think they'd think you were crazy. Good. And the same with Medicaid. So we're moving in the right direction. If Kaiser wants to build a couple more hundred buildings, we can probably move more. I'm kidding.
Thank you.
The only thing I would just say, one other thing on this question that I'd be surprised if we all didn't agree with, is that the lack of transparency is still really a major impediment. Healthcare is still the only sector of our economy where at the time of purchase, we don't know what it's going to cost, who's going to pay. And you can't really have a competitive system without greater transparency. So we've got to work on that if we're going to get there.
Excellent point. Thank you.
I'm Mike Miller.
With what group?
I'm a physician, does health policy
Good.
for a long time now.
Long time troublemaker.
Yes, just like you, Tom. In the mid-late 90s, the concept of people really didn't need health insurance, all they need access to health insurance, access to health care was sufficient. That concept petered out. It went away. It went extinct. But in the last 12 months or so, I've seen it reappear. And I don't expect either of you to agree with that concept that access to health care is all people really need. They don't need access to health insurance. I'm just wondering how prevalent you think that concept is and how it might be impacting how we move forward, if at all. Thank you.
Well, I think it's a critical question that we've attempted to address in a series of ways. The Community Health Center program is an example of access to health care that doesn't necessarily imply access to health insurance. I've always associated all healthcare systems anywhere in the world in the form of a pyramid, where at the base of the pyramid you have preventative care and primary care, and you work your way up and become more and more technologically inclined until at the very top of the pyramid you have MRIs and heart transplants. Every society starts at the base of the pyramid and they work their way up until the money runs out. In the United States, we start at the top of the pyramid and we work our way down until the money runs out. And that's the question in large measure that you're a question. How do you get to the bottom of the pyramid care and providing those primary services that in many ways could be preventative services that preclude the need to go up higher on the pyramid? We're not doing a very good job of that even today, and that's really ought to be one of our challenges. How do we get full pyramid coverage going forward?
Tom, any comment?
Yeah, well, you're always going to have some level of uninsured, even if you have, quote, universal coverage to insurance. And I'm sure there'll always be some people who don't like that idea and say, let's have access through, I love community health centers, through community health centers. But we're always going to have 10, I don't pick your number, undocumented, non-residents who are not going to get Medicaid. So you're always going to have some kind of safety net below that, no matter where you are, certainly in the border states. And so I think you're always going to have some, there's going to some population that's never going to be insurable unless we, fundamentally change these programs. So have you seen more people talk about access rather than, coverage and insurance, access to healthcare? Yeah, I think to me the real issue is, I think most people, most conservatives even think low-income access to fundamental coverage and insurance is the right thing to do.
Good. Last question
As you get
here.
further up in the income stream, I think they feel less strongly about that.
Thank you.
Hi, my name is Alifia Masawala. I'm a physician, and I recently left the Obama White House as a senior policy advisor in healthcare. The question I have for you is, what do you think the trajectory for macro will be under this administration? What sort of changes should we anticipate or expect from this new administration?
Well, Tom's the administration expert, I think, better than I. I'll let him start, but I can weigh in as well.
I think my phone must be broken. They haven't called me. No, I've talked to some of them a lot. I'm not sure what they're going to on macro. I think fundamentally macro was written by the House and Senate staff largely on the Republican side, and they're pretty wedded to it. And a lot of Republican members spent a lot of time on it. I don't think, certainly Tom Price, who was in the House at the time, was very aware of it. I think MACRA is pretty fundamentally locked in with most Republicans, and it was a House and Senate thing. I was somewhat bipartisan, I think, but it was largely driven by the chairman of the House and Senate Republican committees at the time. I think it's highly unlikely to change. I think it's pretty much locked in. I don't think there's a lot of feelings about rolling back MACRA.
I agree with that completely. It's one of the better examples when we think that polarization in healthcare couldn't get much worse. We passed 21st century cures, we passed MACRA. We did things that most people wouldn't have predicted, and there was an overwhelming bipartisan vote on MACRA, partly because everybody wanted to get rid of the prior system. It was such a crazy, convoluted way of reimbursing physicians, but partly because I think it was a statement on the part of almost everybody interested in eliminating fee-for-service, that we'd come up with a mechanism statutorily that, at least at the federal level, creates the opportunity to move to a more rational system. Obviously, a lot has to do with the way it's implemented and enforced, and how much of a priority it is, and that's the open question right now. To what extent will that have priority in this administration? I don't think, as Tom said, I don't think anyone really knows yet.
Quick question, last question from me is, one of the things that's in we had the question around what's causing the escalation in prices in health insurance. One of the things the insurers talk about is the insurers' tax on them, and that they bake that into pricing. What do you sort of see happening with and is there much conversation about getting rid of that, the realistic conversation about getting rid of the tax on insurers?
Well, there's always talk. I don't know if there's, as we've seen over the last couple of months now, it's almost impossible to reach consensus on how to address whatever changes we're going to make to the ACA, and this is another example. I'm sure most people would probably be supportive of repealing taxes, but the question is, how do you fill that void? Is there an offset? What do you do for revenue if going forward, if the ACA remains? Is it further deficit spending? And so I think insurers have raised this as a priority, but at least right now, I don't see a consensus in Congress about what to do with ACA generally.
Any other comment? Was that?
Yeah, in the House bill, the Speaker Ryan's bill, it's gone. It was immediately gone originally. So I think it's highly likely that all the taxes on devices and on insurers will be gone. And I think they're going to look. You can debate the merits of it. I think they're going to pass something for July 4th. I think the freight train slowed down a little bit, but they have no choice. I don't think, they move a little further right, they lose their moderates, and it's a difficult thing to get to 218 votes, but I think they'll get there. And I think they'll get there for July 4th. I think they'll pass the bill and send it to the Senate, and the Senate will be, as usual, more moderate, and that will cause its own, so they can get something done. But I'd be shocked if they don't come up with a consensus in the House to get 218 votes to do something, and my guess is the insurance tax repeal will be in there.
The last 15 seconds each. What's the one thing you didn't say that you wish you had said, or the one thing you said that you just love and you want to say it again?
Bipartisanship, bipartisanship, bipartisanship. If I could say that about 100 times, let's try to figure out a way to do this in a bipartisan way. I mean, it's just so essential. The American people are yearning for it. They want to see it. They want to see cooperation. They don't want to see the uncertainty around all this. So the more we could emphasize that, one of the troubling things the speaker said is that if Trump didn't work with Republicans, he might even work with Democrats, and he was saying what a tragedy that would be. And I don't know if he really meant it the way it came out, because I hope that he really doesn't. He's worked with Democrats, and Tom was incredibly good at working with Democrats, and so I think we've got to figure out ways to do that to go forward, and that's key.
Tom?
What did I forget to say? I love Tom Daschle. I said no. It's hard, and given the way the years started out, I think it's unlikely that they're going to start working together on a bipartisan basis, but I wish they would. I mean, if you look at the makeup of Congress, Senator Schumer likes to cut deals. I think all the Republicans know that. Ron Wyden is a great guy, easy to work with. Not always easy if you're the leader, and but he knows healthcare really well and is a really smart guy. And people forget, if you look at 2012, a month before Speaker Ryan was picked as the VP candidate, the big news in healthcare was the Ryan-Wyden bill. Senator Wyden and Paul Ryan, who were good friends, I assume they still are, had spent a year together working with a bipartisan moderate. It was all the rational people in the world said, this is the answer to healthcare, and they had worked on it for a year and come up with it. So they know each other well. They're both very good guys. And, the politics drives a lot of things, and the world's gotten nastier, more political. But, if most of these guys, you left them in a room together, they could work things out. And Ryan's a great guy and a smart guy. Ron Wyden's a great guy and a smart guy. The people involved here in the leadership roles actually get along pretty well. And if it weren't for the grenade throwing on both sides, they probably would get along pretty well.
Ladies and gentlemen, thank the panel, please.